Hi, I'm Dr. Mike Millie, and I'm here with Dr. Jamison Spencer, the current president of the American Academy of Craniofacial Pain. Spencer, thanks so much for being with us.
Thanks, Mike.
Well, there's a lot of patients out there who don't know that they could use some treatment for getting oxygen during the night, sleep apnea, snores, that type of thing.
Yes.
Tell us a little bit about the symptoms that someone could look for that would indicate they would need help, and then what type of help that they can get.
Great question, Mike. So as a general dentist, this can be a little confusing because some of the things that we've looked at for years and thought that they were just parafunction. This was, we weren't sure what was causing it. It's emotional stress, it's occlusion being off, whatever. We're starting to now realize through the research that this is potentially an airway problem. So, for example, anterior wear. You know, why do people grind out here like this? And so many people we see anterior wear. Well, now we believe it's they're biting forward to protect their airway. Head tilt, chin lift, we do in CPR. The patient's doing it themselves.
Airway open.
Exactly. Other symptoms or signs, tori, mandibular tori. That's from a lifetime of clenching your teeth. Scalloping on the border of the tongue. Snoring, obviously. So if we have snoring. As a dentist is looking at the teeth, if they'll just gaze a couple centimeters back, if you can't see down the throat, that might be a problem.
You might have a closed airway.
You might have a closed airway. So big time. So as you start seeing more and more of those things as a dentist, as you start seeing lots of posterior restorations, as people are breaking down their teeth.
By grinding, sure.
Now I think it's appropriate to question what's causing this? And not just put a piece of plastic on the teeth to sort of mask the problem, if you will, but to get to the bottom of, could this be actually a life or death situation of sleep apnea?
So then what would they do? The treatment possibilities would be a CPAP machine, an oral appliance, surgery.
Yes.
So what does the patient then go ahead and do? They see the dentist for an evaluation, and then maybe a home sleep test, or send them for a polysomnogram at the sleep center?
Again, first step is going to be kind of a paper screening, typically by the dentist, looking for signs and symptoms, talking to the patient. And then usually the next step is to refer them to their family doctor, or if appropriate in your community, directly to a sleep doctor. Where I work, I do a lot of dental sleep medicine and TMD in my practice, so I refer literally 2 or 3 patients every day to the sleep doctors in my community. So that's a nice way to do it too. After evaluation, then treatment will be decided there. So if they have severe obstructive sleep apnea, for example, probably we're going to put them on CPAP first. If they have more mild sleep apnea, we may go directly to an oral appliance. Even if they have severe sleep apnea, unfortunately, 20 to 50% of patients who go on CPAP can't tolerate it. So those patients then end up coming back to us for oral appliance therapy, and this is lifelong. People don't get fit with an appliance or fit with CPAP, and it goes away.
Okay. Anything else you'd like to tell us before we close? What these patients should know about?
Well, for the American Academy of Craniofacial Pain that you mentioned that I'm president of too, our academy makes the connection between TMJ problems and sleep apnea. And again, recognizing that for patients particularly, there's patients out there who believe that their TMJ problems are either, again, psychological, it's stress, it's bite being off, they need braces, they need surgery, stuff like that. We're finding that it's actually more simple than that if you understand the underlying causes, and for patients that gives them a lot of hope.
Great. Spencer, thanks so much for
being here. My pleasure.